We're recording now, so you can start whenever you're ready, Jackie.
Okay. All right. I'm just gonna. Are you gonna follow the chat, Mark? Because I was gonna log into it on my phone to follow the chat as well. If there's any.
No, I'll follow it. That's okay. Yeah, that works fine.
All right. Good morning. Thank you, everybody, for case reviews January. Nice and warm in your homes or at work, so we'll enjoy the good temperature and hopefully a warm beverage. Moving forward, confidentiality. This information is privileged. You should not be sharing it or distributing it in any form or matter to comply with our HIPAA mandates. And moving on to case one. Case one is of a 58-year-old female. EMS was called to a trailer park. They found an unconscious female there. They had proper PPE usage. They found her to be unresponsive to painful stimuli. Her area was open. She was not protecting, and she was not breathing. She was otherwise pulseless, and that was it was assessed within the first minute of contact that she had no pulse, no respiratory effort, and GCS of 3. The past medical history that was available to EMS was that she has a history of alcoholism, heart disease, and high blood pressure, and that her son, who was the individual who contacted 911, had said that she's been hallucinating for the last 3 days, and now he can't get her to respond at all. So this was in the morning or late morning. They noted that she was jaundice. They started CPR with a Lucas device, and they confirmed asystole. They did note in their documentation that there was a delay to access her due to extrication. I believe it was more to remove her because of whatever room she was in due to extrication. Within a minute, they started suctioning, and they noticed that she had copious black secretions concerning for an upper GI bleed. They placed an I-gel. They placed an IO. Unfortunately, or I should just say without editorializing, the first epi was given 10 minutes after patient contact. VFD reported that the patient was unresponsive and bradypneic upon their arrival, but she lost pulses within their assessment of her. And yeah, I apologize. Let me back up a little bit. So she was agonal with fire's arrival, and then as they were extricating her out, she became pulseless and apneic. So that 10 minutes may actually be from when they witnessed her arrest. So the blood glucose was checked at 14 minutes and noted to be 20 milligrams per deciliter. She got another round of epi, and her hypoglycemia was treated with D10. They ended up placing a definitive airway with an endotracheal tube with video laryngoscopy and bougie first attempt at 17 minutes. She went into this rhythm, which they identified as VTAC. They shocked her at 200 joules on our biphasic devices and gave her another milligram of epi. At 26 minutes, she had another pulse check, given another milligram of epi, and she was noted to be in an accelerated idioventricular rhythm. And then at 27 minutes, she had gotten ROSC with a heart rate of 50, a blood pressure of 48/26, a respiratory rate of 12, and a GCS of 3. She maintained ROSC at the 29-minute check with not a significant improvement in her blood pressure, but an increase in her heart rate, and noted that she was hypoxic despite a definitive airway at 48%, and her end tidal was at 17. And that at that point, the decision was made to start transport at 32 minutes. Another pulse check a few minutes after initiating transport was that her heart rate had decreased down to 77. Her blood pressure had improved mildly from the 48/26 to 70/42. Her SpO2 increased to 72, and her end tidal remained at 20, and she was started on a pressor. They checked another glucose, and the glucose had now normalized to 196. And at 38 minutes, She had a heart rate of 107, a blood pressure of 99/60, respiratory rate of 12, and an SpO2 of 88, and tidal of 17. And they arrived to the hospital at 40 minutes. Their assessment of the patient's condition included a cardiac arrest, hypoglycemia, GI bleed, suspected hepatic dysfunction secondary to this skin assessment of jaundice, and respiratory arrest. So in reviewing this case, I thought this case was really complex. As you can see in their assessment of what was going on with the patient, she had multiple etiologies for potential reason for her arresting. They documented that they had a delay in care and that they were able to intubate her on first pass after using a supraglottic airway using both video and bougie, and that they used end-tidal CO2 throughout. I would actually add here too, under the good, is that this case was presented to me by EMS in discussion for why we're presenting it today. So what I would put in the good section here is also that a dispute between the two agencies about what's the most appropriate care, and then working out a resolution in real time that I believe led to this patient's better outcome than sustained cardiac arrest. So discussion with respect to each other professionally, allowing for one of the two people that were in disagreement to come to a resolution that didn't, in my opinion, negatively affect the patient. So the bad where we can do better is that there's no 12 lead obtained, and that our recommendations are to wait for 10 minutes before initiating transport after gaining ROSC. So in the emergency room, she was noted to be hypothermic with a temp of 90.5. She continued to be hypotensive with a blood pressure of 58/32, and her SpO2 was 79%. They noted that she had fixed and dilated pupils. She had scleral icterus, abdominal distension, maybe from jaundice, maybe from GI bleed, or maybe even from spontaneous peritonitis, bacterial peritonitis. They noted that her capillary refill was delayed. Her initial VBG showed that she was quite acidotic at 6.76. PCO2, which we monitor in our end tidal, is 37. Bicarb was very, very low, so she's very acidotic and not compensating. Her lactate, normally it should be under 2, hers was 20, and her hemoglobin was 9.4, so low, but not devastatingly low unless she completely bled out within an hour or two of EMS arrival, where we won't see the hemoglobin match up to the actual value that the patient might actually be having. So this suggested that she wasn't a massive GI bleed despite the black emesis that they noted. She rearrested in the emergency room. A femoral line was placed. They were able to get ROSC back. They started on pressors. They started on antibiotics because of her hypotension and her hypothermia. And also potentially even her hypoglycemia could be speak to bacterial infection. And then she was started on a bicarb drip because of how low her pH was. They noted that she had recently presented prior to this event for COVID-19 pneumonia and left a skilled nursing facility against medical advice. The patient was resuscitated and stabilized before going to the ICU. She continued to decline in the ICU, and given the information about her prognosis, her family elected to make her DNR, and she was pronounced dead 6 hours after admission. So in this particular case, the EMS crew had stated that he would not have checked the patient's glucose because of the fact that it's no longer in the AHA recommendations for PEA asystolic arrest. And that is true. In 2005, they removed hypoglycemia out of the H's and T's, and that it was the other agency that had suggested it. And although it is not part of the most recent guideline, it was a decision amongst the two crews that decided that what could be the harm, although there's some which I'm going to present to you that says there is some harm, but I'll speak to where I think the harm is and how you can work through this and still treat the patient, but reduce the chances of harm in the long run. So in 2005, they removed hypoglycemia out of the AHA protocol. So hold on, I'll have to make sure that this doesn't get another interruption. So in 2015 in Critical Care, the Critical Care Journal, they talked about, well, they alluded to why maybe the hypoglycemia was removed. They looked at the Get With the Guidelines Resuscitation Registry from 2000 and 2010. So for a 10-year period, looking at all adults in cardiac arrest. They looked at the survival, the neurological outcomes, and the chances of getting ROSC. Of the 100,000 plus patients in this registry during that 10-year period, a little over 4% or 4,000 of those patients had received dextrose in cardiac arrest. They didn't speak to if the patient's glucose was low or if they were normal, if they just got it as protective or they were actually treating hypoglycemia. So protective against hypoglycemia or treating hypoglycemia. But they noticed that patients that had received glucose in the cardiac arrest phase had lower survival rates, worse neurological outcomes compared to those that didn't receive it, although there was a correlation of an increased chance of getting ROSC in patients that had received dextrose. So that probably speaks to what you find when you look into this on the AHA side of things, is that it can be detrimental and not make the patient's outcome any better. Now, since then, hold on. All right. Since then, there's been numerous case reports, which I just pull up two here, that talk about these are patients that were hypoglycemic and that they had suffered cardiac arrest, but they either was attributed their cardiac arrest was from hypoglycemia or that they responded to dextrose and allowed for them to get ROSC and didn't lead to a detrimental, horrific outcome. And what in reading these studies as well, they also mentioned that there's more research, more data going into why hypoglycemia may lead to cardiac arrest besides the fact that glucose is low. They noted that pathophysiologically, that as our glucose gets low, we have more and more epinephrine that is released systemically, and that can lead to cardiac irritability, such as arrhythmias, for example, torsades, or leading to patients that may physically not have any lesions in their heart, but as their glucose drops and more epi is dropped out, or responding with their sympathetic nervous system, that they actually suffer type 2 MI or myocardial infarction. So what I would say is that we should not just give dextrose to all patients. We should be judicious about who we are giving dextrose to, and that should be for identifying patients that are hypoglycemic, and that those patients that are likely to be hypoglycemic would be our diabetics or our patients that have nutritional problems. Either they're an alcoholic or they failure to thrive, they just don't have any stores of glycogen to create glucose, or normal patients that have normal nutrition and normal pancreatic function or liver function would be able to create glucose in the event that there's a starvation mode. Now, there has been part of this discussion, there's talk about, can we trust a glucose in a peripheral spot in the middle of a cardiac arrest? Is there vasoconstriction or ischemia? Could it be inaccurate? it could be inaccurate, but that's the same, I would speak to what we do in the hospital setting as well as extrapolating it to the pre-hospital setting. We check finger sticks on patients in cardiac arrest or not in cardiac arrest. Sometimes we don't know that they're hypoglycemic until our lab value that was came back from an IV is low, but oftentimes we're checking in real time a point of care glucose, in that there may be a factor of discrepancy, but ultimately if we are seeing a value that's 20, I would believe it. If you want to check it again, you can check it again, but I would treat it. Now, this may cause some conflict because it's not in our protocol for treating H's and T's in a pulseless electrical activity patient. So if Dr. Mock or Dr. Whitwer is on the call, would you guys like to speak to your thoughts about what EMS should do?
Yeah, I think that if you have actually, if you've gotten if you have hypoglycemia proven or suspected because of your finger stick, treat it. I think the hypoglycemia protocol would probably come into effect on this anyway. You don't have to go simply down a cardiac arrest protocol. If you suspect because of the patient's, I don't think you need to do a glucose on every single person, but you should, if you suspect it, do it. If you have enough time, do it. We should do a glucose on every stroke patient. And the same thing applies. If you've got hypoglycemia, treat hypoglycemia. It's one small step, as it were.
Yeah, and
remember that if you've already given epinephrine to the patient at that point, the glucose is likely to be high.
if they have a ability to create it, but yeah, exactly.
If they have a normal, if their body is not in a depleted state.
Yeah. And that's
Yeah,
what go ahead.
I would agree, and I think the fact that we're using D10 rather than an AMP of D25 means that we're less likely to suffer any bad effects from taking the sugar too high.
Exactly. Agree.
Great. And that's why, as a reminder, that if you are trying to be picking the patients that are most appropriate to check a glucose, a diabetic history, a nutritional problem, either they don't take in nutrition or their liver doesn't function normally. And then I know that in speaking with some of the docs at Peace Health, when you guys are calling in for a pronouncement, that they have asked me, why aren't they checking glucoses? And I've informed them about the fact that it's not part of the AHA protocol as it is now, in that to be graceful about discussing if they really want a glucose or not, as in it's not even in our own guidelines for any level. But
I think we should probably, I don't like to leave, in periods of stress, I don't like to leave things in any kind of a confusional state. So if we want them to check the glucose, we need to tell them to do that, and we need to add it to our cardiac arrest algorithm as well. And we can do that very simple. Yeah.
I don't know if it's all the docs that are asking you guys to check a glucose in your cardiac arrest pronouncements, but I know that I've asked, and I know that some of the docs have come up to talk to me about it are our newer docs. So I don't know if the previous docs are the ones that are also asking you guys. Can any of you speak to that? If you guys are on the call, I'm sure you've had cardiac arrests. That's all right. So we can make this more black and white instead of gray territory in our protocol. So moving forward, I'm going to do a little bit atypical for our case reviews. So it's going to be a 6-year-old female that never existed because I couldn't find a case, but that's okay. I think it's still important to still discuss it. This was brought to you by one of our assistant MPDs because of last year's experience. So a 6-year-old female that EMS is called for a sick case. They find this little girl with a fever, sore throat, and a rash. PPE usage is appropriate for our pandemic situation and appropriate for this condition. The patient's awake, her airway's open, she's protecting, her pulse is present, she has a rash, there's no active bleeding. 5 minutes after fake patient arrival, the vital signs were obtained. Heart rate's 118, no blood pressure is taken, respiratory rate is 20, and her weight is appropriate for a 6-year-old. And then when you look at your hand-heavy or your Braslo or whatever device you use, I use a pediatric app. Let's pull it up real quick so I can tell you if you're a PediStat. But anyways, you know that this patient's abnormal vital sign here is only her heart rate. Past medical history reported as none, in that she's complaining of a sore throat. She has less energy than normal, and she's had a fever, but they're unable to quantify it for you, and her symptoms have been going on for the last 2 days. They said that she developed a rash today, and that's what prompted their call to you, and they've been treating her with just some Pedialyte. Within the 5-minute mark, we talked about the vital signs that were faked obtained, and transport was initiated at 11 minutes because there's no reason to delay. There's no life-threatening issues. They got a SAT of 99%. Her temp is 102.7. Another set of vital signs for serial vital signs, which is the only set of stable vital signs if we're reporting stable vital signs, were obtained, and now her heart rate has normalized to the normal range for her age, and she is dropped off at the hospital at 25 minutes. There's no hospital outcome or feedback because this patient never existed really, although that was only because we couldn't find any cases that you guys had ran, but we suspect that you have come upon this patient last month or in the past. So this is a patient with Varicella Zoster virus, and it's abbreviated VZV. It's been mostly eradicated by vaccination that occurred or came out in 1995. It prevents 90% of all infections, but of those 10% or those unvaccinated, which this would be a case most likely related to an unvaccinated, although it could be in that small 10% probability. But the prevalence is highest in 4 to 10-year-olds. There's more of a predilection with this disease or this virus in this winter and spring months, in that although kids' presentations are usually mild and uncomfortable but not life-threatening, it's much more detrimental in adults, which is this picture of, actually this picture is of a HIV patient. So it's also not only more severe in adults, but also in immunocompromised patients, adult or children. And also a major consideration in pregnant patients because it can lead to varicella zoster congenital syndrome that affects the ocular or nerve tracts, so leads to cataracts or vision loss. It can affect brain growth, microcephaly. It can also cause discoloration, pale marks on the skin, but also can lead to asymmetric or small limbs, as well as meningitis related to this virus. So in pregnancy, a patient that contracts varicella zoster is at really high risk. One, they're already an adult by the fact that they probably are an adult because of the fact that they're pregnant, but then also the risk to the child, the child in utero. And then I got one more picture. Yeah. So transmission is airborne, usually with coughing or sneezing, although that can also be related to contact with lesions. These are like liquidy lesions, our vesicles or our pustules, not the ones that are scabbed over. It's highly contagious. 90% of the people that come in contact with any of these, this vector of airway or skin that are either under immunized or are the unfortunate 10% of the vaccinated will get this disease. And that in the primary infection, it's chickenpox or varicella, they're synonymous, but in the reactivation, they're herpes zoster, which is a picture here showing very similar kind of vesicles, macular rash, and in a dermatomal distribution, but it also can lead to post-herpetic neuralgia or Ramsay-Hunt syndrome too.
Should tell them what Ramsay-Hunt syndrome is.
Yeah. So I knew I should have looked it up before, but off the cuff, it's I believe it's going to be affecting one of the distributions of the facial nerve, but specifically the V1 distribution to the face, and potentially lesions within the eye that can lead to blindness, that you really want them to be presenting to the hospital, but also to follow up with ophthalmology. Let me double check that.
No,
I didn't lead you guys astray.
perfect answer.
Okay, good. Sweet. I was like, anyways, but yes. So symptoms, looking this up as always is the case, reminds me some of the stuff that I don't remember. But so symptoms are 10 to 21 days after exposure. So you may feel like you have lucked out after you find out that some kid had chickenpox and you don't get any symptoms, but you have up to 21 days before you know if you're in the clear. And that once the symptoms start, especially the rash portion of things, that they can last for 7 days. So actually, let me reword that. So 10 to 21 days after exposure, in that they says it'll last for 5 to 7 days, but some of the sources that I was looking at said that the whole symptomology from your URI type symptoms to the crusting over of all of your rashes can be up to 4 weeks. So I would say 2 to 4 weeks, but it may be up to 3 weeks before you get symptoms. So in the beginning, especially more so in adults than children, that you're going to see muscle aches, anorexia, maybe a headache, runny nose, some nausea, and as those kind of like non-specific flu-like symptoms or COVID-like symptoms resolve, then they end up developing more of like a fever. Most of the time it's a low-grade fever. They might have some malaise. In that, interestingly, the first lesions are going to be oral, and that had to do with the fact that how you get this disease. It's through the viruses contained in the droplets of the upper respiratory secretions. So as you inhale them or you ingest them from your mouth being open, then you first get your initial lesions and rashes in your throat. And that's oftentimes why some people will complain of a sore throat initially, because they actually have erythematous vesicular rashes in their mouth, and that those oral lesions spread out to a rash on their body. Pediatrics may only have the latter part of the presentation, which is the fever, the malaise, and the rash, and they don't complain about the other symptom, the prodrome. So physical exam, you're going to find small red macules. Macules are non-raised lesions. There can be blisters that are clear. Once they develop blisters or pustules, it becomes pretty pruritic. And then as the rash gets fluid filled, They can umbilicate or have like a little dimple in the center, which is the picture on the bottom. And then as they umbilicate, they're about to erupt and that they start to scab over. Usually the rash has a predilection initially in the chest, the back, the face, and then it can spread distally. Interestingly, in my med school teaching, there were only a few rashes that could lead to rashes that present on the palms and soles. And this was not one of the rashes that they taught us, but this can also be in the genitals, can be in the palms, the soles. So that what they used to teach you, which was Coxsackie and rickettsia and syphilis that only affect the palms and soles, you can add varicella there too. So diagnosis is predominantly off of signs and symptoms. If you have a problem with identifying the ultimate diagnosis, you can send a PCR off of the fluid-filled rash or fluid-filled pustules. There is also blood testing, but the vast majority of these are just going to be diagnosed by their presenting signs and symptoms. And then treatment is largely symptomatic management in our less compromised individuals, so like our pediatric patients, so calamine lotion, you may have heard like oatmeal bath. And then if our more concerning cases, which are going to be our adult or immunocompromised or our pregnant patients, they can get a varicella zoster immunoglobulin shot, and then they can get antiretrovirals. Antivirals, so that'd be like acyclovir or ganglicyclovir, as long as it started within the first 48 hours of rash, and some sites had said the first 24 hours of rash. Let's see if there's anything else I wanted to tell you guys about that. No. So we don't really have anything in our protocol for rash unless it's like related to like anaphylaxis or anything like that. I added this slide on Tylenol because of the kid's fever, and to point out that if you would treat that kid for the fever, technically we wouldn't, because it was 102.7, not greater than 103, which I think is fine. If you really felt like you needed to treat that kid's fever, you could have by contacting online medical control. But what's probably more helpful is take all the clothing and all the blankets and jackets that the kid probably is wearing, and maybe decrease the temperature. Don't turn the heat up blasting in the back of the ambulance in the wintertime. And then the other thing I wanted to mention is that this case was brought up because we had an outbreak of varicella zoster in December. I don't remember the numbers. I feel like it was in the order of 30 to 40 people that presented with this through public health reports. I'm not sure if anybody else in the MPD's office can speak to that.
I remember that number too, roughly.
Okay. And, so we bring it up because one, in Clark County, we have had an uptick in December. We have a large non-immunized population in our Eastern European folks, and that although many of us are vaccinated against chickenpox or varicella, we still have a smaller percentage at risk. And with the contagiousness of this disease at 90%, it's a good probability that if you're under vaccinated, you're going to get it. And then as a little side note, you can get blood tested to see if you have the antibodies against varicella, but there are people that are non-responders. Either they've had varicella in their own primary infection and they don't develop antibodies, or they've been given the varicella vaccine multiple times and they don't have antibodies after that. And I am part of that category, as I'm a non-responder.
Just as I think I consulted and did a review of the case from the Salem area about 15 years ago of a young woman pregnant who got varicella during her pregnancy and went on to die of severe varicella-induced pneumonia, and essentially the same kind of syndrome as you would have with COVID. She had because basically pregnancy is a hypoimmune state. It's a otherwise you reject the child, and so she ended up getting essentially like a COVID pneumonia and going downhill pretty fast.
That's actually, thank you for that tidbit of knowledge as well. And I failed to mention that the most common sequela of varicella in the adult is going to be pneumonia. And then the other risk, that's probably the second, is a secondary bacterial infection over the rash. And then along with the next more common diseases in the adult. But those, as a good reminder, is that in the adult varicella patient that you're really worried about pneumonia, amongst other things.
Yeah, and I think the key thing for EMS is just if you're seeing a rash that could represent that, just being sure to follow your infection control precautions.
Yeah, and that was my little plug with the fake call, is that the eye protection, the mask and stuff like that, and then gloves to decrease your chances of touching any of the secretions on the rash, but it's all aerosolized, so it's inhaling through your nose and through your mouth.
Well, it's just basically the same precautions, the same super PPE precautions that we do for COVID.
Correct. So
right now we should theoretically have very low risk of contracting varicella from the public right now. Because we are theoretically doing extreme PPE. Now, it's also interesting that we've had an outbreak of chickenpox or varicella, and 3 years ago we were the #1 place in the country for measles. Sort of a harkens back to your thing that this is an under-immunized county.
Mm-hmm. Especially in our adult population, that this is something that not only are we talking about measles or varicella, or even our current immunizations that are available for this pandemic, that it's not just a little discomfort, it can put your life at risk.
Just a reminder for all of us over 50, we should be getting our Zoster vaccines.
Yeah, definitely good. All right, our next case, unless there's any other discussion, is of a 13-year-old female at school, the PE class. Chief complaint, or the call, was for an injury from a fall. She was complaining of left lower leg pain. PPE usage was appropriate for the current conditions, and she was found to be awake. Her airway was open. She was protecting. Her pulse was present, and there was no signs of active bleeding. Within 4 minutes of patient arrival, they were able to get a heart rate of 90, blood pressure 124/84, a respiratory rate of 20, and they documented her kilos at 80 kilograms. So for a 13-year-old, I believe that was what we were saying. Yeah, for a 13-year-old, she is actually 176 pounds. Past medical history, none was reported. And the story was that she was running at PE. She slipped because her pants were too long, and that she had said that her knee went one way and she went the other. EMS had documented that she had dislocated her left knee, and that she's never had a history of the same. She didn't strike her head. She didn't lose consciousness. I wish that I could call somebody out in our meeting to say, is there anything suspicious about what this slide talks about? But the good news is that I can't see the chat, and the thing is that all of us that are listening can just think, bigger kid, 13 years old, no previous injury, kind of slipped, fell, went one way, and what do we think was the issue with her knee? So, as mentioned, 4 minutes, her vital signs were obtained. At 7 minutes, she was given 50 micrograms of fentanyl. She was given at 12 minutes a pillow splint to try to stabilize her knee since it was still hurting her. They note that her kneecap was dislocated laterally. And they initiate transport at 15 minutes. They get another set of vital signs, noting that her blood pressure is increased to 142/90, but the rest of her vital signs are normal. And they give her another 50 of fentanyl. And it's my understanding from Dr. Mock that they notified Legacy, I don't know if it's through Pulsera or whatnot, but notified them of a knee dislocation coming in for a 13-year-old. Is that correct?
That's correct.
Okay. So in reviewing this case, just looking at the EMS document.
Version of it.
What's that? Or if someone's not supposed to be, or if someone's not really asking a question or making a comment, make sure you're muted. So the mechanism of injury, they documented a pain scale, which oftentimes is not documented. They got serial vital signs and they gave her a narcotic. They monitored her SpO2 afterwards. And where I think we can improve is making sure that we are documenting what we know, and that knowing and what we document or we tell other people, we need to be really certain about what we're talking about. So is this a knee dislocation? Is this a patellar subluxation or dislocation? And then I personally would love to see that we documented that we contacted parents and got consent, especially as we're moving towards giving them controlled substances, and then doing a CMS assessment, at least initially, but especially again after any major change. So either if you're trying to splint them, reduce them, or whatever you're trying to do, that you need to be checking a CMS. And when I say reduce, we only reduce for pulseless. So in the emergency room, I don't have her follow-up. Dr. Mock, do you have it?
I reduced her patellar dislocation.
All right. And she go home, she get admitted.
She went home.
Did you do any workup, imaging, CT, angio, anything like that?
No.
All right.
No x-ray, nothing.
Perfect. So patellar versus knee dislocations. Am I stressing something that is potato, tomato? Is it really the same? Is there really anything different? Am I being overly nitpicky? So I'm going to show you 3 cases briefly to kind of demonstrate radiographically the differences. So, and these are all cases that I have had. So 23-year-old male, non-contact twisting injury to the knee, or direct contact to the intermedial aspect. So that's basically the mechanism, but this particular person said that they twisted and that their knee went out, and this is the x-ray. And you can see that in the AP view here, that you've got your femur, you've got your tibia, your fibula, and that they're like basically sitting right on top of each other. And then it looks for, if you don't look at a lot of x-rays, it looks like it should look, things are kind of aligned, except for this little thing over here, and that's the patella. So the patella would be normally sitting on top on this straight leg AP view. A little harder unless you're familiar with what you're looking at in the lateral view. Next one is of a 62-year-old woman who had a total knee replacement, who came in 24 hours after her injury. She said that she hyperextended her knee because, and she's probably can get from the picture here with the subcutaneous tissue, but she is morbidly obese. But she said that she couldn't quite get to the walker, so she was trying to walk. She hyperextended her knee and her knee hurts, but she came in by private vehicle. So I get this x-ray, and that previous picture where that femur was like sitting right on top of the tibia isn't quite the same picture. And then that picture here is to show you what a normal lateral would look like. And then this one was CrossFit Games when I was in residency, 31-year-old female who comes in with knee pain, no previous patellar, like, let's just call it no previous knee issues that she's ever complained about, and that she describes her mechanism is that she's pulling probably 100 pounds of something behind her, but she has to do these lunges to pull it. And as she plants down on a lunge, all of a sudden her knee locks up and she has excruciating pain. And this x-ray shows her lateral view, bent knee with the two pieces of her patella now being stretched by the ligaments attaching them. So she has broken her patella. So all knee complaints, all drastically different pictures, and we're going to talk a little bit about the patellar dislocation first. So mechanism injury is usually a non-contact twisting injury or any kind of direct contact that pushes the patella medially to the lateral side. Most commonly, they're going to dislocate or sublux laterally. Our risk factors are going to be any patient that has a history of Ehlers-Danlos, kind of that flexibility of the ligament. They can have some problems with the patella morphology, how the patella is created in utero. And then there could be some abnormalities with anatomy in regards to trochlear dysplasia, or with a tibial tubercle or trochlear groove distance. Usually you're going to see your patellar dislocations in anybody who is young. 13-year-old is also a possibility. Inactive, not necessarily elite athlete, but just being active, and that had led to the mechanism. Usually the patient's going to present because they can't continue the activity, they can't bear weight. There's swelling, closed swelling to the knee that doesn't look normal. Although sometimes these patellar dislocations do spontaneously relocate, or when they extend their leg, or that they have had a history or somebody's pushed on it, history of it, so that they've pushed it back in, or that someone, not EMS, pushes it back in. And that some people, that if this is their first presentation, they might get an x-ray because there could be something else going on, such as the CrossFit woman. But most of the time, there's no x-ray. It's based off of, especially if there's a history of subluxation in the past, that it's based off of physical exam and reduction. In if you attempt to, let's rephrase. If in the emergency room that we try to reduce it and it doesn't go back in, we might get an x-ray to confirm that we're dealing with what we suspect, which would be a patellar subluxation or dislocation. But most of the time, you don't need an x-ray to confirm that, as also demonstrated by Dr. Mott. Treatment is some type of patellar bracing, if that's a neoprene splint or whatnot. Physical therapy, in that some patients will go on to have surgery, especially if it subluxes frequently. And that although surgery reduces it dislocating again, it doesn't bring it to zero. So if they've had surgery, 24% of them will go on to dislocate their patella again, and 35% of non-surgical will go on to dislocate. And then I don't know if there's any patella here, with the quadriceps tendon superiorly and the patellar tendon inferiorly. So knee dislocations are a whole different animal. So it's a very rare incidence. Less than 1% of all orthopedic injuries are related to knee dislocations, in that it's likely underreported because up to 50% of these will spontaneously reduce because their knee is super unstable. In that, in order for it to occur, you have to knock out 3 to 4 of the ligaments. So you have to knock out your ligaments in your knee, include your PCL, your ACL, your lateral collateral, and your medial collateral. So you would have 1 remaining ligament to keep that knee stabilized in order for this to occur. The risk factors, like the patient underlying risk factors, is morbid obesity. It's more common to occur in males than females. I think that is more related to the energy, that if it's related to the energy that caused the injury, that it's more active sports or motor vehicle crash related, which tend to be more of our male population. And then it's going to be based off of the mechanism of injury and the physical exam that's going to key you into this condition. So the mechanism could be rotational injury, that the leg got caught and the rest of their body kind of twisted and pivoted, or this could be like a motor vehicle crash where their knee went into the dashboard, or it could be a football injury or some type of like running injury where they planted on their foot, somebody hit them in their knee, they rotated the rest of their body. So get that kind of mechanism in your mind about, and it also could be kind of like a fall, if they fell down like a flight of stairs and their leg got caught underneath them and twisted abnormally. So this picture here shows a knee dislocation with the patella off to, I believe is going to be medial aspect. You can see that the anatomy is that you've got an atypical knee, a large effusion, or maybe this is actually the femur anterior to the joint. And then you may see this type of injury when you're looking at the straight leg from the anterior view, where it has this dimpling. This dimpling is likely related to a rotational injury with a true knee dislocation, and it's oftentimes needs to be actually sedated to be able to get it relocated. It's not something that is going to spontaneously go back in. And besides that, CMS is going to be huge to be assessing. I'm going to show you a video. So I told you some of the mechanisms, but they don't have to be those ones I just talked about.
Our athlete doing exactly what he should be, preparing for his junior year of football. Takes a little fall there, but if you slow that down, you see his left knee dislocates posteriorly. So when we get
Bad day, right? All right. So besides the injury to the ligaments in the knee, there's a chance of injury to the nerve. 25% of the patients that have this type of injury will end up having that type of injury. They'll also have a chance for vascular injury. They didn't report how often those vascular injuries, but the peroneal nerve is likely affected, and the popliteal vessel is the one that we need to watch out for, as well as tibial potentially as well. And that up to 60% of all patients with knee dislocations not only have a ligamentous injury, but they also have a fracture and then obvious soft tissue injury. Diagnostically, we will get an x-ray to confirm, which some of those pictures previously had showed you, but also because there's such a high risk for vascular injury, we evaluate for the integrity of the blood vessels. So oftentimes that's done by CT angio of the extremity. If there's an injury to the blood vessel, it's such as a pseudoaneurysm or a tear in the blood vessel, or even a clot in the blood vessel posteriorly, that they undiagnosed, if there's a ischemia for, I think that the numbers were saying ischemia for 8 hours leads to 90% amputation of that leg. So this is a young person that has the whole future, but even an old person probably doesn't want to lose their leg either. So these are ones that, especially if it reduces spontaneously, you get called out for it and you see them and you're concerned, or that's a possibility, you need to really strongly encourage these patients to be evaluated before they get to the point where their leg is ischemic. And then we might do ankle brachial index, which is blood pressures in the arm and the leg, and comparing for evidence of flow, MRI, and then a consultant, which could be vascular or orthopedics, and that's more in the hospital setting. Treatment can be operative and non-operative. It could be delayed to do operative after a period of time if there's no injury to the vessel, although operative can be quite large surgeries with open reduction and X-fix placement. I've got another video to show you guys. So this is a gentleman who was in a motor vehicle crash, took his knee to the dashboard. He's completely awake. They're working on reducing his knee. I'll go back just a little bit.
He's got pain medicines already
sedating
on
him
board.
with propofol.
Are you awake still? Are you awake?
He was talking, so he's no longer after
What are you
sedation.
doing? Explain to us.
Just pushing on the femoral condyles here. Trying to reduce.
Oh, you felt it.
So remember, at least 3 to 4 ligaments have been injured in order to have a true knee dislocation, and the chances, 60% of them, which you could feel, if you were listening to the subtlety of that video, you could hear the crepitus. The other thing is that the vascular component to it, where undiagnosed or unidentified ischemia to the vessel of the leg has a high probability for amputation. So our protocol, I bring this up, one, because Dr. Mock had this case and it seemed like there was confusion about what the condition was, and that EMS had reported this as a knee dislocation, which is vastly different than a patellar subluxation. But also because in speaking with one of our EMS colleagues, they had told me that they were told that they can reduce patellar dislocations in the field. We don't have a protocol for any optional reductions unless they're pulseless. And that is really one inline movement to try to regain pulses. So we should not be working to reduce any type of dislocation unless they're pulseless. I don't know if anybody else has any thoughts or want to bring up any tidbits.
No, I just wanted to bring it up because it's being comfortable with the distinction is really valuable in the field. One, because a patellar dislocation is something that that's a reasonable refusal, whereas a knee dislocation is a very high risk injury, and knee dislocations, because they're so unstable, often spontaneously reduce. So your exam in the field before the patient is packaged is really critical in diagnosing a knee dislocation, and when, particularly with ground level falls in the obese, it can be easy to miss a knee dislocation.
Yeah, absolutely. All right, last case. Thank you guys for your attention. Case was a 60-year-old female. This is not her, but kind of gives you an idea of her complaint with facial swelling, fullness in her neck, stuff like that. So EMS gets called for a sick case. They find this patient complaining of face and neck swelling, and that she was also complaining of weakness. PPE usage is at pandemic level. They find that her airway is open. She's alert, she's protecting. They noted that she's pale, she's cold, she's cyanotic, and she's diaphoretic. Vital signs obtained 2 minutes after patient contact show that she's tachycardic. Her blood pressure's on the softer side at 106/74. She's definitely tachypnic at 30, but her SATs are 99% on room air. Her GCS is 15, and she's an average sized person, 90 kilos. Her past medical history is that she has a history of lung cancer and she's getting chemo. And then she also has reactive airway disease. I think this is like COPD potentially, but reactive airway disease was in regards to COPD. Her history is that she was complaining of being weak and tired. She had presented to an outside medical provider who had prescribed her azithromycin for 7 days, and that she's been taking it, but her face and neck have been getting swollen since taking it. She's been, in addition to the Z-Pak, has been taking Benadryl because she thought that maybe it's related to the Z-Pak, and that her throat and tight were feeling swollen, especially with swallowing. Her throat is tight with swallowing. She had no chest pain, no shortness of breath, itching, or hives. Let's see. All right. So a lot was done because a lot of time was with this patient and because the patient was far away from a hospital. So lung sounds were clear. Vital signs I just told you about in the 2-minute mark. At 5 minutes, they started an IV. They checked her glucose, which was high but not needed to be intervened on. They put her on a nasal cannula because she was clearly having respiratory distress between her respiratory rate as well as her cyanosis noted. They got some additional history was that the patient was not vaccinated against COVID. She had a recent negative test. They saw that she was sitting in a chair. She was pale. She was cyanotic. Her face and neck were visibly swollen. They started her with 25 milligrams of Benadryl at 13 minutes, and they reassessed her vital signs. Her heart rate had decreased mildly to 112, but her blood pressure had plummeted significantly to 60/40. She was still tachypnic, but her stats were still 100%. Her end tidal was 25. They walked her to the gurney and she became progressively dyspneic, but better with that oxygen. They initiated transport 16 minutes after arrival and they started her on an epi drip. Initially at 30 mLs an hour, and then they increased it to 60 2 minutes afterwards because she didn't seem like she was responding. She had another IV placed and she had another set of vital signs that showed improvement in her blood pressure, now 96/68. They felt that they should increase her up to 90 mLs an hour on that epi drip, but when they rechecked her vital signs again, approximately 9 minutes afterwards, her pressures were down in the 78/45 range. She was still tachycardic, and they elected to intubate her because they thought that she was experiencing respiratory fatigue. So they RSI'd her with a 200 of ketamine and 140 of Sux. They intubated, they intubated her after a second attempt with a 7.0 BL and bougie, and got vital signs after intubation a minute after. So we'd expect potentially for her to become hypotensive with our RSI meds, but her heart rate was 114, her blood pressure is 115/76, her respiratory rate is 16, GCS of 3, and tidal of 36. I will mention that they documented stopping the epi drip prior to intubation, which and prior to giving her ketamine, which I would have said keep it on, especially because you're getting at least some blood pressure management with the epi that you have her on, but nonetheless. She got fentanyl first for her post-intubation sedation, and she got another set of vital signs, and then ketamine following the post-intubation sedation pain control, another dose of fentanyl at an appropriate time interval, and then her next muscle relaxant was actually Versed following that, in that she arrived to the hospital 67 minutes after patient contact with delivery vital signs of a heart rate of 106, blood pressure 102/76, respirators of 16, GCS of 3, and an end tidal of 54. So I'm using Dr. Mock's explanation of his review. So he had relayed that the patient was appropriate to consider anaphylaxis in a patient with facial swelling, but several features don't fit. Gradual onset over several days, cyanotic face, no itching or hives, no angioedema, unlikely for anaphylaxis to cause respiratory failure without angioedema, and no evidence of improvement from epi. Good documentation of intubation, good post-intubation sedation. And then the bad would try CPAP before intubation if fatigue is the indication, or at least document a contraindication. That said, if not improving with epi, definitely wise to change course as you did, and wise to stop to get additional assistance. And then there's no indication for Benadryl if anaphylaxis is what you're suspecting. Epi needs to be the first attempts. Benadryl is an optional adjunct for bothersome itching. So this patient arrived to Legacy Salmon Creek, diagnosed with a large SVC, superior vena cava thrombosis, which caused the patient's facial swelling. She was transferred to Emmanuel for IR intervention, successful intervention, but then had sustained multiple PEA arrests on the table. They thought from migration of the clot. She did get ROSC, but developed severe acidosis and renal failure. Given advanced cancer and poor prognosis, her family elected to withdraw care. And that the discussion went on to say that this was likely her outcome regardless of whatever pre-hospital or in-hospital intervention the patient had. Svc thrombosis is often a terminal event in patients with advanced cancer. So not a common pathology for us to see in the hospital or pre-hospital setting, but something to be aware of. So that's what we're going to talk about. So Svc syndrome, or superior vena cava syndrome, it's related to a partial or complete obstruction in the SVC, and that could be from tumor or from thrombosis. Patients often present with facial or neck swelling. The veins in their neck can be enlarged, as well as the veins in their chest. They'll have upper extremity swelling potentially. They'll complain of respiratory complaints such as dyspnea, cough, or orthopnea. The etiology can be one of three mechanisms, which is either compromised vessel anatomy within the lumen, impaired venous flow, or diminished wall integrity. Malignancy is oftentimes the biggest culprit. Sometimes this doesn't have to necessarily, it could also be a benign tumor, benign mass, and up to 40% of these, but also something to be considering that it doesn't have to be a tumor, cancer, or benign. It could also be from pacemaker wires or from intravascular catheters, such as like for administration of home meds, like a tunnel catheter, or even for our patients that are getting dialysis through a tunnel catheter in their chest. They estimate about 15,000 cases in the US per year, and that diagnosis is determined by ultrasound or CAT scan of the chest or MRI, and that what the treatment could include, especially in the pre-hospital setting, is elevating the head, trying to decrease the amount of engorgement to their head and neck with simple elevation of their head. And then the patient may need to get chemo, radiation, or remove that device in those iatrogenic causes. Oftentimes they're anticoagulated. They may get catheter-directed TPA, or they can get endovascular repair or clot retrieval if it's a clot. So we don't have everything in our protocols, and nor do I expect for us to have that condition, but I thought that what's most appropriate to review for this patient would be our allergic reaction and anaphylaxis protocol, which we do have guidelines for. And just as Dr. Mock had pointed out in their review of their case, is that Benadryl is indicated for a mild reaction. If you are thinking that your patient is severe and you're not just dealing with pruritus or hives, you're moving towards much more aggressive management, and that's going to be starting with epi, potentially Benadryl as your second line, bronchodilators if there's any evidence of reactive airway disease, and steroids. So severe reaction is going to be represented by the fact that the patient is an extremist. So they're going to be wheezing, they're going to have accessory muscle use, they're going to have shock, they're going to have upper airway swelling. As a reminder of what qualifies. And then if they're not responsive to these measures, then starting them on a norepi drip. Any other comments to add to that case, Dr. Mott?
No, it's a really challenging case, but there are a couple of things that can mimic anaphylaxis, and so it's important to keep a broad differential when you're treating someone who presents like that.
Absolutely. I would say I had only one time that I'm aware of in my practice of SVC syndrome, but it was in a 20-something-year-old who didn't, I think homeless, didn't doctor, had the unfortunate diagnosis of lymphoma undiagnosed, and presented with those complaints, as well as a supraclavicular node. But anyways, it's not common, but definitely something to keep your mind, be aware of, and be in your differential and how you would potentially manage that, which is supportive, and elevate the head and deal with ABCs. So in review, in regards to hypoglycemia and cardiac arrest, you can't get anywhere if you're running on empty in regards to glucose. So fill up the fuel for that patient to be able to potentially get ROS back, and hopefully it was early identified and allowing for less likely poor neurological outcomes. Patellar dislocations are different from true knee dislocations. Think of your mechanism, think of your physical exam, and think about your recommendations if this patient doesn't want to come to the hospital. As Dr. Mock had also pointed out, one is appropriate for refusal, the other one is highly against medical advice refusal. In your SVC syndrome, these patients are going to have facial swelling, neck swelling, vein engorgement, where they wouldn't have that before, can most likely be related to malignancy or tumor impeding blood flow back from the brain and the head, or the head and neck, but also can be caused by iatrogenic devices that it can be caused iatrogenically by devices that are implanted into the neck or the chest. And then Varicella zoster is highly contagious based off of respiratory secretions and contact with the liquid parts of the pustule or the vesicles, in that mask and eye protection and gloves are mandatory, and very, very worrisome in any adult or immunocompromised or pregnant patient. This is just a list of my references. Anybody have any questions? All right, thank you so much for your attention. As always, you can reach out to MPD's office anytime. You can reach out to myself or Dr. Mock while we're in the emergency room, or send us an email if you have a question or concern. The nice part about these cases this month they were initiated by other than me, so I'd love to put out your guys's wishes on what you would like to learn about or what was concerning or difficult for you on your call. Sweet.
Thank you, Dr. Gadbois. There's no questions in the chat.
All right.